Hey guys, we're going to go over atrial flutter. Okay, so as you can see here, I have a 6-second strip, and it obviously looks abnormal compared to this one. So what is a flutter? A flutter is when you have your automaticity cells, like I showed in the earlier video, where if the SA node failed, you had these little cells and they would take over on their own beat. And if it needed help, they would do 60 to 80. Okay? Now, let's say one of those automaticity cells gets real angry. Caffeine, stress, meth, you know, all the good stuff. Well, now I have this automaticity cell who can, like we stated earlier, should be 60 to 80, and it can discharge automaticity, it can discharge on its own. That thing starts firing. Okay? It starts firing, and what ends up happening is it's called a re-entry loop in the right atria. So when I start discharging, what happens is the discharges, impulses, start doing this and this, because I'm discharging more, I'm discharging more, I'm discharging, and it keeps going round and round and round and round. Well, when it's in that re-entry loop, every time that it comes around, it's trying to get in to the AV node to then be sent downwards. Well, when this little guy is discharging at this rate, he's sending it at about 250 to 300 beats per minute. Okay, so now just imagine 250 and 300 beats trying to get into here to send down and cause a ton of chaos in those ventricles. Well, the good thing is that when the AV node accepts an impulse and tracks it down, it then also has a repolarization state. So then it has to repolarize, so then it can't accept an impulse that fast. So when it does that, it actually blocks it from being upsourced one more time. However, when you're looking at flutter, it goes off of a conduction. It goes off of a ratio. So let's say that foci up here wants to send 300 beats into the AV node. Now, a ratio, like I was talking about, if I let in 2 beats for every 1 ventricle, my rate would be 150 beats per minute. Now, that seems a little confusing. So I'll show this EKG as an example. Do you see these right here? Now, a characteristic of atrial flutter is these P waves. Oh, Jesus. These P waves right here, see how they look like teeth Nice saw blade teeth right there. Now if we go up, look at our P wave over here. Rounded. There's no sharpness. While the other one down there is like this. See? It looks like a teepee compared to a rounded. So now I'm looking at this and I see these teeth right there. These are technically P waves, but these are called F waves. It's just a way of characterizing that these are flutter waves that are coming through. They're still P waves. They really are, because they're coming from above the AV node, above the ventricles. It's causing a contraction, so we're still getting a P wave, but a way to think about it is these are F waves because they're flutter waves. So even if I were to write this out, it would say I have flutter waves here. Because technically, if you look at it, yeah, sure, they are P waves, but they're not what we think of a normal P wave, where it's that normal lump like that. So we have to be able to describe them, in a sense, medically, to someone, right? Like, hey doc, I just got the EKG on patient in room 2. It looks like he has a flutter due to the presence of flutter waves or F waves. Okay. Now, when talking about the ratio right here, the 2-to-1 that I was talking about, do you see that there is 4 of these saw teeth? Well, if I was to write that in a ratio, this would be a 4-to-1 ratio, because there's 4 for every 1 QRS. Does that make sense? So if I have 1, 2, 3, 4, so my first number would be 4, and I have 1 QRS. So I have a 4-to-1 conduction. I'll tell you why that matters. Because, remember how I showed you right here that if I had 300 beats per minute that I was trying to fly into the right atria, right here, I'm doing 300. If I had a 1-to-1 ratio, I would have a heart rate of 300, right? Because for every beat this tries to send, the AV node takes, doesn't block any. So if I'm sending 300, the AV node takes all 300, and then the ventricles get all 300. Okay, so now let's say I have a 2-to-1. Now, if I have a 2-to-1, that just cut that in half, right? Because now half is coming through. I'm getting 150 beats. So you're still sending me 300, but I'm only taking 150 out of here. Now, to look at that at the 6 lead, we would cross these out, and you would have a QRS right here. And there would be 1, 2. 2 between the QRS. Now, notice how when there's 4 here, right there, see the spacing? Look at that spacing. That's pretty wide, right? So now this has got to be less than 100, obviously, because of the spacing. We got a decent space here. Now, if I did a 2-to-1 ratio, so now let's forget about the rest of this for right now. And I had a QRS right here. Well, I have 2 between it. Look at that rate that I have. That's not a lot of distance, right? So when we look at this and we go, okay, if I had a 1-to-1 ratio, those QRSs would be on top of each other. There would be no hiding from these guys right here. So that's how you monitor for a ratio. So now you go and you get this patient and he comes into the ED, chest pain, shortness of breath. First thing you're going to do, EKG. I do my EKG. I get my rhythm. And it shows here's my F wave. F. F. So now I can call the doc or the charge nurse and say, hey, I have a patient out here, Mr. Jones, chest pain, shortness of breath, did an EKG, and he has atrial flutter with a 3-to-1 ratio. And your charge nurse is going to say, oh, that's kind of fast. Let's get him back. Okay, so that's why that matters. This 4-to-1 right here, look at that. That's spaced. Now what if I landed that boy right there and we have 1 F wave between the QRS? Yeah, that's what I mean of how a 1-to-1, a 2-to-1, this is just a simple way of measuring these. Okay, so now that we know that we have a automaticity foci, that's all squirrely in here, that's all irritated. Now we have to fix it. We have to try to fix it. Okay, well, the main thing you want to worry about when you're looking at fixing is that if I were to send in 300 and it turned into a 1-to-1 ratio, okay, so that would be, let's say 300, right? Because we can be just like that. So we're going to say our heart rate is 300 right now. Okay, we have a 1-to-1 ratio. We have 300 beats per minute. Hypothetically, if I'm sending in a heart rate of 300, do you think my cardiac output is going to be decent? No, because these are flying so fast in the ventricles that even if I do get a drop of blood in there, boom, they're already gone. If I can send a drop of, it's gone. You see what I'm saying? So if it's going that fast, the ventricles can't keep up. So these patients, when they can't keep up and they have low cardiac output, what are they going to have? Chest pain, shortness of breath, dizziness, confusion. Not so much as confusion, but you get what I'm trying to say here. Blood's not reaching the body. We're in a dysrhythmia right now. Okay? And especially if I'm at that much right there, at 300 beats. And you're telling me that my ventricle is going to be able to keep up with the amount of blood that I got coming in? Ain't happening. And it's going to get tuckered out fast. And when we're sending in 300, it usually leads to a ventricular arrhythmia, like VTAC, VFib. Okay, so now, here's another thing we have to worry about. Because of the way this is going up here, the automaticity is discharging at 300. We're not fully emptying these atrias. How can you at 250, 300 beats per minute? You can't. So if I have all this volume of blood and I'm going at 300, that means the atrias are going at that rate. So there goes a drop of blood. We're not able to passively slow down here because that's the AV node's job, is to slow us down in a normal heart rate so that we can finish all that blood that we just kicked out. Right? Normally, the AV node right here catches that impulse, slows it down, so your extremely slow atrias can finally do some work and drop that blood. So if I'm going at 300, 250, nothing. Now, because blood is still going to keep coming into the body, we are going to have backup blood, right? So let's say we have 100 mLs. And each time and our heart rate's 300. Each time, hypothetical, I'm just throwing a number out there, we're getting 10 mLs. We're getting 5 mLs. But we have 100. But we're going so fast that we cannot empty this fast enough. So what ends up happening is you end up getting stagnant blood swirling around in here while receiving new blood into here. And what does stagnant blood do? It clots. So while we're getting rushed in with blood, now we formed a possible blood clot. So now we have new blood rushing in, stagnant blood chilling in here, and a blood clot. What it likes to do is a spot that it likes to be found, that blood clot, is off the side of the heart. We have those extra pouches. Remember the auricles? It's those like flappy ear things off the side. Those clots like to hide in there. Okay, now we have a patient that we have to be worried about because we got a big old fat clot chilling in here, possibly, depending on how long that they've been in this arrhythmia, right? So if we have a big old fat clot chilling in there, now we have to worry about the risk of monitoring our patient now for strokes, pulmonary embolisms, wherever that this thing gets stuck, we have to look for it. So on top of monitoring your patient for his cardiac output and a heart rate of 300, now we have to be watching him for confusion, facial drooping, stroke-like symptoms, PE symptoms. We can also get that thing in the coronary arteries. If it gets through in here, and nothing gets stuck in the lungs. So then it comes through here. Here comes my big old fat clot into the ventricle. There it goes. And remember, the atria feeds the coronary arteries. So now we got coronary arteries hanging out. And our big old fat clot can get stuck in there, causing us a possible MI. So you see how this is an all-around job to watch out for because of that clotting, because of the heart rate that we could be sitting at. Okay. Now, treatment for these patients is warfarin, right, which is a lot of times we see these patients who have history of atrial fib, atrial flutter, are usually on a blood thinner right here. And the reason for that, like I just explained, is that we have to watch out for them having an increased risk of blood clots. We have to monitor these guys for that. So the doctor's going to prescribe them warfarin so that we can decrease them getting a blood clot. Okay, now let's say your patient comes in and he is running at a 2-to-1. So a 2-to-1 would be 150 of 300, right? So he's sitting at 150. He has chest pain, hypotension, and we'll say that's like 70/40. We know the heart rate is 150, and he's got shortness of breath. This is a pretty unstable patient, right? Well, per ACLS, a patient who is unstable needs to be cardioverted with electricity. So we need to start looking at an electrical cardioversion. Here's the problem, is that if I do a cardioversion on this patient, and this is new onset, no history of it, the patient is not on any type of blood thinner, right? He doesn't take that at home. You know, we ask him, hey, do you have a history of this? No. Do you take any blood thinners? No. Okay, so now we're worried. We might be having a blood clot in here because we don't really know. We didn't witness it ourselves when it started. And we can't cardiovert anybody longer than 48 hours. So if they've been in this rhythm for 48 hours, we can't cardiovert. I mean, the risk versus benefit is way too huge because we send in electricity, okay? And he does have a big old fat clot right here. We send in, that's my lightning bolts. And we put the pads on and we put it at 50 joules. We shock them. If you ever see somebody get cardioverted, they jerk like crazy, right? It's a pounding. It looks like somebody gets punched. Well, when we cardiovert like that, because it's so forceful, we can run the risk of breaking it off and throwing it into now the system. Now, we just made a traveling blood clot because the force was so big that that thing stuck on that wall, dislodged, and said, "Outskis." Now, our patient is at a high increased risk for some type of disease profile wherever the blood clot sticks. So that's why that's really tricky to have on these patients. So now, let's say our patient comes in and they're normal-ish. They have a heart rate of 120 beats per minute. Okay, well, what we're going to want to do for these guys is rate control for them. Okay, so we're going to do our calcium channel blockers, primarily like diltiazem. Okay, now we can also do our beta blockers. Okay, because we're trying to decrease the workload on the heart. So we're going to be doing one of these. We can also do amio, okay, because remember, amio is a potassium channel blocker. So we give it also for our VTACs, VFibs. And basically, what it does is it prolongs the repolarization of the cardiac cycle, and it decreases the amount of times that we can have a stimulus. Okay, so we want to do rate control. Now, we can also do cardioversion. Just remember the old rule. Thinners greater than 48 hours that they've had these symptoms, right? And another one that's risky that comes with it is new onset, because they don't know what these symptoms are. And we don't know anything about their history with that. Okay, so now we have them. We also have our antidysrhythmics. Oh, she was with the wrong. Okay, and we can do this one, and this one can help convert them back into normal sinus, or once we convert them, now we can maintain sinus. So if we were to convert this guy up here to sinus rhythm, well, we need something to keep them at sinus, right? Because we have that pissed off foci sitting in there. So we need a way to just keep the heart rate together. And what do we do with that? We do a drug called ibute, also called covert. We can also do amio, and flecainide. The first line treatment, though, for these patients And this would be them going to the cath lab, things like that. And it's going to be a radiofrequency catheter ablation. That is the first line treatment for atrial flutter. Right there. Okay. So they go in there and they burn that foci. They go in there and burn it. So now once it's dead, it can't discharge. Okay.